Good evening, everyone, and welcome to the latest structural heart disease webinar sponsored by CVI. And this is the latest in our series of Nail It with Nadira. Today, we're going to be talking about transcatheter tricuspid repair and CIED-related TR. This is another CME accredited activity with the learning objectives as described here. This activity is approved for 1 credit should you choose to claim it. We have a fantastic group of faculty. I am introducing this, and then Dr. Nadira Hamid will be moderating the session with Hursh Naik as faculty, as well as Matthew Price and Steve Romero. We'd like to thank Abbott, Medtronic, and Shockwave for the gracious support of this activity. We could not be here without you. Thank you very much for the sponsorship. If you'd like to claim credit or CME for this activity, you can view this webinar and then at the end, log on to this website. You'll also find enduring material there where you can also download and print your certificate as you need. And then finally, please keep in mind that in July 24th to 26th, we'll be back in Austin for CVI 2025, the Operators Enclave, and we look forward to having you all back there. So with that, I'll turn it over to Dr. Nadira Hamid to kick off this evening's webinar.
Thank you very much, Paul. Let me share my screen. All right, so thank you everyone, and good evening and happy holidays. And thank you for spending the next hour before Christmas with Nail It with Nadira, with my colleagues and friends. We'll be talking about transcatheter tricuspid repair in CIED, which stands for cardiac implantable electronic devices related tricuspid regurgitation. So it's a huge topic and it's very challenging, especially when we are considering for TriClip therapy for these patients. And so the agenda for the next hour, I'll give you a brief introduction to what's exactly CIED related TR. We'll go through 3 great cases by not only myself and Paul, but also by Matthew Price and also Steve Romero. And then lastly, we'll close off with data presented by Dr. Hursh Naik at the recent TCT this year, just a month ago, from the Triluminate pivotal trial with regards to patients who underwent TriClip and had CIED-related TR. So the data from that is really exciting. So just a brief introduction. We know this is really common, and especially with the TR awareness, and certainly the presence of CIED is a risk factor for tricuspid regurgitation progression. And a recent paper by the HVC, about 36% of patients have previous CIED-related TR, and a lot of them have been presented for the replacement technology. And majority of them, 25% of actually moderate to severe TR, actually have CIED. And so most of the time in the past, the literature have shown that these TR are diagnosed at the time of autopsy or surgery. And so with the huge, interest and awareness on explosion of TR and imaging, that we are able to actually diagnose it really relatively early nowadays. And the proposed mechanism for CIED-related TR is actually there's 6 types. So one, you have a direct leaflet impingement. The second one, you have a leaflet, the lead entanglement within the subvalvular apparatus. The third one, you have a perforation through the leaflet or the pap muscle. The fourth one is where you have adherence or laceration of the lead. So you cause scarring or fibrosis of any type of the tricuspid apparatus in the path of the lead itself. The fifth and the sixth, we do see it, the fifth being the RV pacing-induced dysynchrony, and the sixth being the thromboembolism from leads causing pulmonary hypertension. And so we have seen a lot of these, and these are the 6 main proposed mechanisms for CIED-related TR. And the paper by Dr. Han, recently by the HVC, you can see an algorithm of how these patients are treated, especially when you're thinking of replacement. So you're thinking about whether you need lead extraction. If it's not suitable, do you jail the lead, especially when it comes to replacement? But how about in terms of tricuspid repair? What is the data out there? Have we done it? And certainly is approachable with regards to tricuspid clip therapy. So when we think about TR and CIED-related TR and tricuspid repair, I think of these points. First, trying to think of are there treatable gaps? And when you want to see these treatable gaps, is the key, as you know, me and Paul always say, is imaging. You know, we need to see the grasping views. Where is the grasping views? Are they the RV inflow outflow views, typically like your simple without the CIED, and the biplane imaging, the target views? You want to see the transgastric views. And during the procedure, obviously you have shadowing. So use other modality of imaging besides TE, like 3D ICE in my previous webinar talk, and use the 3D navigation, which I'll show you in a case that we actually did and was very, very helpful. The other thing to think about is maneuvers to manipulate the RV lead, which me and Paul have published papers with the Agilis maneuver. And most importantly, when handling CIED related TR, I think is really need a close collaboration and multidisciplinary approach with your EP colleagues in your site as to what is the planning for these patients, because they are complex. Is there a repair or replacement technology for this patient? And if you extract the leads, what is the backup plan if things go south? So certainly collaboration with your EP colleagues is really, really crucial. So in terms of maneuvers, I mentioned the Agilis. This is a case that we did pre-lead manipulation. You can see on the top side, the lead is really central, multiple segments. You can see the slack of the lead on the fluoroscopy on the right-hand side. And below, you can see when Paul actually used the Oscar catheter to manipulate the lead all the way to the septum. So certainly maneuvers like this is certainly helpful in terms of planning for either repair or replacement technology. So without further ado, I'd like to present a case. I think I'll hand it over to Matt Price and Steve Romero to present the case.
Thank you, Nadira, for the kind invite and really a great introduction. And I'm here with Steve Romero, who's a fantastic imager. We're at Scripps Clinic. I thought this was a really great case, which highlights many of the things that you talked about, Nadira. So this is a 75-year-old female with class 4 symptoms who was well treated for her symptoms and for tricuspid regurgitation with a diuretic, an ACE inhibitor, and SGLT2 inhibitor. She received a permanent pacemaker, dual chamber, some time ago, approximately 12 years prior, for Sick-Sinus syndrome. And as far as our records went back, she had had severe TR for at least 5 years. So whether it was present before or developed after, the pacemaker was unclear. Transthoracic echo will show some representative images, showed 5+ tricuspid regurgitation, a normal left ventricular ejection fraction, an interesting normal LA size with a normal right ventricular function. We routinely, I mean, what we learned from the Triluminate Trial and Data, and Paul can weigh in here, is that clinical outcomes, hard endpoints are pretty good if you optimize them with right heart catheterization beforehand. So we did that. Wedge pressure was 10, so her TR was still severe in the presence of addressing any left-sided issues. And you see she has some modest renal dysfunction and an elevated pro-BNP. And you see here EKG, again, when we're dealing with these leads, patients with leads in TR, we look at the EKG, we interrogate the pacemaker. Is the lead being used here? And I think you can see here it's A-paced, but there is no V-pacing. Next, please. And I think it was on that slide, but I think she was rarely V-paced, I think 15 to 20% of the time. So here's some representative echoes. And I know, Steve, you want to weigh in, and we didn't go, it's not a comprehensive look at the TR, but any thoughts on this TR, what your takeaways are?
Yeah, that first shot on the left, thank you, Matthew. You see the lead, you can see it clearly going through the tricuspid valve, and then it really looks biased towards the septum, and it makes me suspicious right off the bat that at least some of the TR is related to the pacer lead. And then the shot on the right, you just see a torrential TR and not much more. But that left image makes me very suspicious.
Interesting, her RV function looks pretty good, right? So when you're thinking about tricuspid intervention, when I see a ventricle like that, irrespective, I mean, pacemaker aside, this raises my eyebrows. This is hopefully very approachable with tricuspid TR. Next slide, please. And Paul or Nadira, if you Hursh, you guys want to weigh in, of course. All right, so here's some now the transgastric view, is our really go-to view to assess clippability. for transcatheter TEER. And you see here, any thoughts? I guess we'll do a little back and forth. Steve, what do you see here?
Yeah, so septal leaflet on the right, anterior leaflet obviously bottom left, and again that pacer lead looks to traverse the tricuspid leaflets pretty close to the septal anterior commissure, more towards the septal leaflet, but also suspicious. And then when you see the color, right around that septal anterior coaptation, more concerning for the lead. At least contributing to
right. So and big picture, good transgastric images. So this is this again goes under the favorable category when we think about tricuspid TEER. The color seems to be.
I don't know about that.
Yeah.
So
We'll see.
know.
We'll see. We'll get some more images in a second. But
Yeah,
certainly
I mean,
the
I think it's not exactly. I mean, it may or may not be impinging that septal leaflet, but it's close enough to the grasping zone that it would make qualification, really challenging, and certainly not for the trial. This would not be in the trial.
Okay, so I won't comment on that. So and the color though is predominantly AS, and the leaflet is somewhat mobile. So the question is there interaction or not? So next slide. And so here we're walking through it. And here the imaging is a little bit worse. You want to weigh in here, Steve?
Because I did it. Yeah, sure.
No. This is transthoracic. You interpreted it probably. You didn't do it.
No, this is T. This is RV.
Oh, I'm sorry, T. Sorry, I'm sorry. It's been a long day. I apologize. Yeah, T. Sorry.
So yeah, on the left you see the RV inflow view, and we're just fishing or putting the cursor in different places, the biplane, so that on the image on the right we see the different spots from anterior to posterior, going right to left, and on the image on the right without color, you see this is a shot where we happen to capture the pacer lead going through the tricuspid valve, and appears to be very closely associated with the septal leaflet of the tricuspid valve, and then the corresponding color picture, you see those two on the right. The TR appears to be stemming a fair amount from exactly that spot.
Okay, agreed. So it's just very suspicious. Next slide, please. And it's just going more now towards the middle of the leaflet, and you're beginning to see the leaflet a little bit more, but again, that's not completely where all the action is. Next slide, for the sake of time. And then posteriorly here, again, we're seeing the leaflets now, but again, that's not where the action is. If you look at the color, the Pisa is more anterior to that. So, so in the area of the regurgitation, the pathology, hard to see the septal leaflet because of the lead and questions of interaction. Next slide. All right, so this is the summary, really. Poor visualization of the grasping zone due to shattering from the lead. There's also a lead draping over the valve inflow, things we worry about. Interaction you have to be careful with. And there is possible lead interaction with the septal leaflet. And how are we going to grasp this? Can we grasp it? And will the amount of TR reduction be unacceptable? Next slide. All right, so somehow maybe Paul, you weren't on the line, but this patient has actually continued to access Triluminate. And I think also is a testament to the complexity of the cases that we did in that trial, right, Paul? So
what I did, we started doing these ones with the steerable sheets a little bit later, and it worked well. And so you just have to demonstrate that there's a grasping zone when you move it, and it looks like you did that between the middle and the lateral,
right?
The middle and right,
exactly.
Yeah.
So you see here, I can't recall what type of steerable, but you can use an Agilis, you can use Baylis, you can use a Oscor. I've even sometimes used ice catheters. So here, on the left, I had some bills, but I think we can't see them here. So this is before pulling away, which is in the middle, and then when we've pulled the lead down inferiorly, which is posteriorly for the tricuspid valve, you see the lead moves quite a bit, doesn't it? And in the transgastric, you now see septal leaflet. It's not perfect. Part of it has to do with the quality of the recording here, but that now you see that you begin to see the septal leaflet. Next slide here. And I also wanted just to make sure that once we pulled it down, did we still have TR? Because was the jet actually interfering and causing the TR? And you see with the jet pulled away, we still have substantial TR. In the middle is the pre, and on the far right is afterwards, I believe, and there's still quite substantial TR. So we still have some, we need to address this. Next slide. All right, so you can see I'm aggressively withdrawing. Now this is, again, we can talk about the concern of displacing or revulsing a lead. This has been there for 12 years. So it's quite fibrotic in the RV. So I was somewhat aggressive pulling back here. And you see, this is just, again, highlighting the first grasp, which is the midpoint of the anteroseptal leaflets. I chose an NTW here because I was unsure of the length of the septal leaflet. And you can see in the transgastric view, there's signs of a good leaflet insertion. And the TR is still there, but more central. You don't see much TR, if any, anterior to the clip. And you also see how nicely nestled now in the PS com is that lead with the inferior pulling on the lead itself. Next slide, please. So now we need to address that residual color. This is after release of the clip, and you see again just anterior to the first clip, mid anteroseptal. We'll see on the transgastric. There is substantial color still, so we need to put in another clip, and we've really moved towards.
Matthew,
really,
looks like it looks like the lead stayed there after you. Did it stay there after you release it?
No, I haven't released the lead yet. I've kept it down, and this is the clip has been released, and now there's still color centrally. Next slide. So now is the second grasp, and you see here we've oriented the clip in the transgastric. You don't even see the lead here because it's quite posterior. And now we've grasped and closed the clip, and you can see the posterior, just posterior or just central to the second clip is our lead, right? And you see a really nice reduction in the TR. Next slide, please. And now this is the result before releasing the lead. And still, there's still a little central jet that's eccentric. Steve, you agree on that?
Yes.
This is really, we did some really nice imaging Steve did through this case to allow us to see those septal leaflets in the grasp. Next slide, please. So now we're going to, I believe, release the lead. So now this is just in real time. On the left, you see the flexing or extending the lead, and it slowly pops back to the center. And on the right is the transgastric and an inflow view after release of the lead. Next slide. So this is at 6-month follow-up. And you see a really good reduction. It was read as 1+. She feels great, class 1. Remember, she had renal dysfunction with a GFR in the mid-30s. It's now 65. Her BNP was in the thousands, I believe, and now it was 117. So a really fantastic result. So a challenging case, but we went through it methodically and carefully, and were able to be successful without having to extract this very old lead. That's it, Nadira.
Yeah, and I just put a couple of learning points from this case, Matt. I thought, the lead maneuvers as you highlighted, and the key thing, good imaging views, like what Steve has demonstrated for grasping from the RV inflow, outflow, the biplane imaging and transgastric. And then a consideration, as you mentioned, which clips to consider. I guess you mentioned, the NTW because you weren't sure, and then followed by the XTW. And then maybe or not the use of 3D eyes, but certainly something to consider if there's some more shadowing, if you can't get a good grasping view. So certainly to consider 3D eyes.
Yeah.
Any other
I was
points?
just saying, yeah. Yeah, I think moving a lead from anterior to posterior is easier than moving it from posterior to anterior. We've done that, and Paul's published some great stuff regarding that. It can be done. It's low-hanging fruit, though, if you have a lot of slack in the lead to pull it down inferiorly. Now, 3D imaging, certainly, I think since I've done this case, we would nowadays have gone very soon to 3D ice. I'm not even sure. We were very sort of early in our learnings in 3D ice in this case, so we didn't use it. But certainly, I think if we did this today, it would be 3D ice from the get-go.
And
Question
Paul,
for the group.
Agree?
Nadira, and the group, one thing that goes through my mind with this case is when Matthew moves the pacer lead and the TR is still there, does that mean that the pacer lead didn't cause the TR? And I have my own opinion, but I'm wondering what others think. Like, could he say to me, Steve, like, you were totally wrong again, and the TR was not from the lead, and so I
I'd
have
love
my
to
own opinion,
comment.
but I'm interested what others think.
I'd love to comment on this. So there's lead induced and there's lead associated, but this is one that I actually think, even though it looks like it wasn't lead causing, I actually think it is the lead, because I think it's the lead embedded in a subvalvular apparatus, and that subvalvular apparatus scars over time and pulls the lead down and pulls the leaflets down. So and you could
totally agree.
You could see it when Matthew was pulling on the lead. Most of the lead is actually pretty stuck. And you're getting a little bit more slack from the SVC in that direction. But a lot of the lead was actually kind of stuck. You're moving certainly the part that's across the annulus posterior, but the rest that's in the RV is really just plastered. And I think it's just that subvalvular apparatus. I think we underestimate how much scarring happens when these leads go into the cords.
absolutely.
100% agree. I mean, we had a case just the other day, Steve, remember? Same thing. It moved a little bit, but it was really all underneath the leaflets where the action was. So, Paul, it's a great point.
Okay, thank you. So just for the record, when Matthew lambasts me in the cath lab, that it wasn't the lead, then we're clear that maybe it still was.
Wow, I never lambast you, Steve.
Well, great case, Matt and Steve. And so moving on to our second case, a different type of CIED case that myself and Paul did. So this is an 89-year-old gentleman with a cardiac ATTR amyloidosis on tafamidis, HFpEF, permanent AFib, has a pacemaker since April 2021, CAD with prior PCI and stage 3 CKD, and has symptomatic TR, presents to our clinic. And so you see this is on our screen TE, and you can see the lead, similar to the previous case, a little mobile as well. This is the RV inflow outflow view, a lot of TR, torrential TR all across from the posterior to the AP view. And then similarly, RV inflow outflow view, just to highlight the lead, you can see on the left-hand side, biplane imaging of the RV lead is certainly mobile, and certainly what's suspicious is what Paul mentioned earlier, that this is definitely an interaction with the subvalvular apparatus. You can see that interaction, the impingement right in the RV there, and the bouncing, and certainly that when you put color Doppler, the jet is all around it. And anterior to it as well, certainly suspicious of that interaction with subvalvular apparatus. And so moving to your RV inflow outflow view, your standard across doing the sweep and trying to find that grasping view. And so starting in your anteroseptal, you can see the top row on the left-hand side, your anteroseptal color Doppler, not much TR jet, and then moving closer to the mid, what you can see is that prolapse and possible flail of that leaflet, of that septal leaflet. So you can see there with a large pizza on the color Doppler on the bottom color Doppler. And on the right-hand side, towards the lead, certainly you can see the RV lead there and also the TR jet around it. And so that, like I mentioned in the earlier slide, you want to see the grasping view for sure to see where you can tackle this case. So here your transgastric view all across the RV lead, and then biplane imaging in your transgastric view, you can see the trajectory of it, certainly in the RV, in the posteroseptal region, certainly interaction. But 3D was really helpful in this case. I managed to get from the transgastric view you see on the left-hand side and 3D MPR. You can see the trajectory of the lead in the posteroseptal and into that pap muscle, into the subvalvular apparatus. And then doing live 3D imaging in the middle and the right-hand side, you can see certainly its embedment. And then as I, move, rotate the image, you can see on the right-hand side, certainly the impingement of the subvalvular apparatus and that fibrosis, as Paul mentioned earlier, that caused this TR around that lead and anterior to it as well, and possible that prolapse and flail. And so, we had the grasping view and thinking that certainly approachable with TriClip, right, Paul? Any comments before I move on to the procedure?
No, it looked juicy. The gaps are a little small, the lead's near there, but we felt we could get around it.
Yeah. And so he proceeded to go on to the right groin as normally for most of our cases. And Paul, you want to mention on the right-hand side, when the 3D MPR, you were trying to do the trajectory. We do with the 3D MPR for trajectory, and you can see the alignment of it wasn't really optimal. And so any decision that or thoughts of your during this moment?
Yeah, it's an uncomfortable position when you've maxed out your L knob and you still have this asymmetry. It's just gonna be a long day. So you start thinking about what to do next.
All right. Any comments, Matt or Hursh? You're thinking that you at this stage?
Well, you say right groin, so there must have been some changes.
I was just gonna say
I
I would
can't
probably move to the left groin if I could.
But I would
I
have
would
struggled for a
have
while
tried-
from the
yeah.
right side.
I still think I would
This is
have
great because I
tried to
really
cross and then maybe adjust under transgastric and sort of get lucky and see if you can get to that AS commissure in an appropriate way, but unlikely, I would think. And then we'd probably have to move to another.
Yeah.
Yeah, I haven't with the tri-clip system ever had to go left groin. So Paul, how often are you doing this? Having
Pretty
to go left?
uncommonly. I think it's pretty uncommon. But one thing, I'll let Nadira talk about this wire position, but you can get a sense of it. Nadira, do you want to talk about that? I'm pretty sure I know what you're going to say.
So, well, I find that using, the bicable with the entrance of the IVC, and when you're seeing the wire at the 5 o'clock position, or 6, the chances of getting that trajectory and the alignment is so much better. But if you've noticed that wire, we've seen in a couple of cases going at 7 o'clock or even 8, that's when you will run into trouble, right, Paul? And then so you're going to
Nadira, can you explain this again? Nadira,
Oh.
if you can use your mouse and tell us exactly, I don't know what you're talking. I don't understand. Okay.
So here is actually on force of your tricuspid valve. So your tricuspid valve is below. So you acquire this in your bicable view and rotate it. So your SVC on top here and your IVC obviously over here as you enter with the wire or the delivery catheter. And you can see here as he enters. So this is, you like the face of a clock. So this is 5 o'clock over here. And we find if this entrance is around 5 or 6 o'clock, the chances of getting that alignment, that trajectory, and in not being a septal hugger is really on point. But if you are at 7 o'clock here, the entry, and it's usually the IVC offset, chances of it, being close to the septal and trying to maneuver out of the septum, and we've seen a couple of cases, right, Paul?
Yeah, and this is it's beautiful what she's showing. Yeah, I mean
so this is your wire is in this SVC.
Yeah, so as soon as because we throw a wire up, a soft J up into SVC, and then we exchange for our Safari over like a JR. And then with the first wire position, Nadira gets this 3D image, and she knows pretty quickly if we're going to have a severe septal hugger or if we have something that's more favorable. I'd say it's pretty accurate, at least 80 to 90% of the time. you know?
Yeah.
So here you can see when we switch to left groin, we're at 5 o'clock with the wire, and you can already predict that you will not have to use as much LNOP. So it's a really quick check, even before you insert a large bore catheter.
Wow.
We should probably show the 7 o'clock wire at some point too. But
Yeah.
yeah, but there was a case we had the other day where the wire was at 7 or 8, and it was just a god awful, a septal hugger.
Nadira, one last time, can you show where the septal leaflet would be in this view?
Oh, right here. So this is the
I
intervention.
see.
Yeah, so it's right here.
So you're,
So we
so you're
already
coming across, I see, so that's
Yeah.
why.
Yeah, so the closer
Okay.
the wire is to the septum, then you know that that's going to be where your guide position is going to be.
And you're hugging the septum. Got it.
That's right. That's right, Matthew. Yep. Pretty cool, isn't it? It's kind of a neat little thing.
Very.
yeah.
Yeah, very.
Nadira, you're building this 3D picture from full volume or 3D zoom or
Just live 3D.
live 3D? Okay.
Yeah,
Simple.
very quick,
Nice.
simple, and you know, all I do is just park here, and Paul will and he can see everything as he maneuvers down into the tricuspid valve.
Yeah, it's
Nice.
the quickest way to steer down too.
Yeah, instead of 2D where you have to manipulate the probe a lot. And so once he maneuvered down into a tricuspid valve, I just go to my 3D, my RV inflow alpha, as you can see, and then click onto my 3D MPR, and he aligns it. And I've just put my crosshair to where I want him to go. And you can see on the right-hand side as he go below the leaflets, and then switching then to your transgastric view on the left-hand side where he orientates the clip. This is an XTW first. And so once, you know, you can see on the transgastric, the leaflets are already in. And so once we have that, we move on to your mid-esophageal view, grasping view. And you can see biplane imaging. So far, so good. I can be able to see the leaflets as you can see on the right-hand side as he bring down the clip arms. You see good clipper bounce. And of course, then as you close the clip, you monitor it and you can see real nice tightening of the leaflets, the septal leaflet, the lateral leaflets for confirmation. And we use 2 images for confirmation, both in your mid or distal esophageal and your transgastric view as well. So here, your transgastric view, you can see both leaflets going into the clip arms really beautifully. And so you know that you have a very good grasp and adequate leaflet grasp of your septal leaflet as well. As you can see, it's very nice and taut. And of course, we release it.
Wow, nice.
So you can see that reduction from a transgastric view are very nice. When you get a good grasp, the first AS, right, Paul? That septal leaflet moving in, really nice. And you can see the immediate TR reduction you can see on the RV inflow outflow view, you know, as compared to the baseline as you see previously. And then no color, you can see that grabs, really good grabs as well. And so what next would you tackle next? For, you know, and I think that's the next thing, right? We see some residual TR. Can we grasp with another clip? And so again, the same methodology is finding that target for the second triclip. So there you are, you have the biplane imaging on the left-hand side and color, that's the target. You have that lead there, and there go Paul say, let's try it. And I'm cringing behind my lad. I am.
Oh.
A little bit. I was like, okay, let's do it. Right.
I mean, some concerns, I guess, your concerns are getting caught on the lead, I suppose,
Yeah.
the grippers and
Yeah, that's the thing. You're right, Matthew. I worry most about, you know, with the grippers, exposing the grippers and getting entangled with the lead. I mean, we entangle the grippers with the leaflets already, and getting entangled with the lead is a really hot mess.
Yep.
But that transgastric shows it nicely where I think you should give it a try. If
Yeah.
you look at that transgastric, because the jet is isolated right anterior to that lead, and the lead is slightly mobile, and which makes me think that you'll probably be able to sneak in right next to it.
Completely agree, Hursh. You know, the inflows don't always tell us the coaptation plane we're shooting for. And the transgastric really is a truth teller. I completely agree with you.
Absolutely. Completely agree with all 3 of you. And so we went for the second triclip, another XTW, repeat the methodology again. So here you can see coming in, and I was cringing because I know in terms of the grasping view, but no fear. So 3D MPR, as Paul bring down underneath the leaflets, and then switching to, as Hursh mentioned, in terms of orientation, the transgastric, and trying to sneak in right next to that, adjacent to that first clip there. And so you can see on the transgastric view, possible leaflet, insertion into the clip arm, and then grasping view. And I knew on the right-hand side, my distal esophageal, I did mid, distal, and this is the image that I see. I tried everything, Steve, and I just could not. And that's when I needed the 3D eyes, Once you see that shadowing from the lead, the delivery catheter, we tried every maneuvers. And that's when I found that 3D navigation really, really helpful, the 3D eyes, So Paul pulled a 3D eyes catheter, he inserts it. And then, like my previous webinar, we do a 3D zoom. And it's essentially, you can see on the right-hand side, he's maneuvering the catheter, right, Paul, to that crosshair. And so really, in terms of, you can see on the top right-hand side, as he moved towards the catheter towards the crosshair, you can see clear visualization of the clip arm. And so once you revert to 2D, you see that clear visualization of that leaflet. So that's essentially, in a nutshell, that 3D navigation that we use. And it's, the more you do it, really quick. It was within a minute we did this, and this was the images that we got.
Nice.
Yeah, and you can see the leaflets within the clip arms, that we couldn't see very well with TEE, and immediately Paul on the right-hand side grasp it. We got good leaflet insertion, and this is the final images, the TEE. You can see here. Really nice.
Yeah, beautiful.
2 clips. I think this is one of our best cases here, and the final results here.
Wow.
RV inflow, outflow. Just gonna press here. Really to really trace from, we were impressed. We were, that we felt that certainly with CIED, this is a true CIED related TR. So you can see the 3D color. 3D and color crop multi-view. The left-hand side was the baseline torrential. It was like 1.5, and you can see down to trace on the right-hand side with just 2 XTW. Really, and the key learning points that I felt, and Paul, please chime in. The target, right? The grasping. I think that's the key thing. And this case, we didn't have to manipulate the lead as the previous case, as what Matt has shown. As long as you know and you can see that grasping view from the mid-esophageal view and the transgastric view. And then, of course, now we are spoiled with 3D eyes, which I love, all of you guys know. I think really helpful, like what Matt has said. And then 3D navigation really was very helpful for the success.
I don't think it's really technically a good idea to do this without 3D nav when you're using ICE, because the 3D nav tells you where you need to go. Without the 3D nav, we actually we turn the ICE catheter looking for things, but it doesn't exactly tell you what you need to be looking for. And so I think the 3D nav is really just game changing. It's great.
We've learned a lot. In the trial, most of these lead patients would either not be accepted or they would be in the single arm, thinking that we could only get 1 grade reduction or a certain amount of reduction. And what we're learning now is that we can actually get these guys down to trace 1+ more than 2 grade reduction. And I think moving on, we shouldn't allow leads to let us not go for the best. And this case kind of proves that.
And the nice thing is we avoid the grief from some of our EP colleagues, bless their hearts, who complain about us jailing these leads. It preserves options. So.
And the last case by Matt. So thank you, everyone. A really interesting case too. So Matt, here you go.
All right. So we have an 88-year-old male with atrial fibrillation. Signs and symptoms of right heart failure, including ascites, being paracenteses, who had a permanent pacemaker placed just 7 months prior to seeing us for extended pauses with the atrial fibrillation. And a recent interrogation showed that the patient was V-paced 27% of the time. He had a heart failure hospitalization did right heart catheterization, which showed that his left-sided pressures were within normal limits, but clearly an elevated right-sided pressure, and he's on really good medical therapy. Next slide. All right, so I'll let Steve walk through his images. These are some highlights.
Wow.
And Steve, you're on mute. There you
Yeah. Yeah. Thank you, Matthew. So you see not a huge jet, but when you're at the leaflet tips, frequently you don't see the biggest TR jet, but there is, a significant jet there, kind of right in the middle, maybe a little bit in the AP canyon. And then on the right side of the screen, you have a biplane image of note. It's somewhat of a horizontal heart, which can make things a little more difficult. And that means that the image on the right just shows the RA and RV not straight up and down, but rather on its side. So, and then the inflow view, the 75 degrees, you see the pacer lead crossing the tricuspid valve, really at the SA commissure, or quite anteriorly at least. You see it there, but the septal leaflet doesn't appear as pinned as the previous one.
True, although it's really, I think one of my takeaways, if you go back one, Nadira.
Okay. So
No problem. Is well, first you see that the lead again, the offending lead is anterior, and usually they should be posterior, and it is challenging to see the septal leaflet. I think the lead is moving with the heart rather than independently, and there you really just, that whole septal area is either shadowed or you can't see it, and especially on the inflow outflow view where we're cutting it anteriorly again, really not a septal leaflet to see. Maybe a little one in there if you cross your eyes. Next slide.
Is the lead going through the leaflet?
Yeah, Paul. I was
Like
just
It
Yeah.
looks
about to
like
ask that.
the leaflet's crucified by the lead.
So,
Yeah.
you know how we're talking about apparatus versus leaflet? If I was looking at this, and you guys correct me if I'm wrong by imaging, it looks like the leaflet is stented open at the septal leaflet is stented open at the interseptal commissure there. Am I not saying, is that what?
Yeah.
Yeah. No, I think you're right, Hursh. I didn't think it was going through the leaflet, to Paul's comment, but we could see what the other pictures look like.
okay.
Yeah, let's go to the next ones. So first you see better now the broad jet, right? There's a lot of TR here, and on the inflow, and we're again AS again. You really don't see much color, but you don't see much of anything because of the shadowing of the leaflet. And as we move a little more centrally, again a lot of jet and hard. Maybe here during systole, you're beginning to see leaflet, right? But again, a question of what's going on with that leaflet there, that lead. Next slide, please. All right, so now it's funny, Stephen. So Stephen did this TE, and he said to me that he thought the lead was clearly impinging on the leaflet, and that we shouldn't just bring him to the lab. And I was sort of disappointed. The guy's 88 years old, frail, getting ascites. I'm like, well, should we just pull it out of the way? Let's just see if it works. And
Can you go back a slide?
See, I didn't
Because
lambaste you.
Can you go back a slide? I think that this last one, right before the academic slide,
Yeah.
when go forward. Is there another one?
Yeah, that's, you want to go back one, maybe one more. But
Okay.
certainly this is not I mean, all jokes aside, Steve is right, is that this is not a case where you although the jet does seem to be central or posterior to the lead, there's a lot of shadowing there, and there's not a clear leaflet to grab. And certainly in the transgastric, it seems like that whole septal leaflet is plastered down to Hursh's sense. So this is not a good TR case. Now, the question is when to be aggressive. he only had his lead placed 7 months prior. So it's a fresh lead, right? So this is Steven said, Matt, we should get this lead extracted. And Steve, I did not lambast you. I listened to you. Okay. So next slide. We can go through. This is just the academic slide showing that, the implant, a long implant time is one of the major risk factors for a complication. And this was a fresh lead. All right, next slide. So they extracted the lead successfully, put in a CS lead, and this is now what we see.
Nice.
Yeah.
And so I know Steve, I mean, I can speak for you, Steve, but now you see the septal leaflet has appeared, right? You see a SA coaptation plane. You see that there's color from that area as well. And then on the inflow outflow views, you actually see a nice long, I mean, look at that middle leaflet, the middle pane, a nice long septal leaflet. And there is some color coming from there as well. So this has changed from a fourth down and long to really hopefully a relatively straightforward case. What do you think, Paul?
I completely agree. This is beautiful. Yeah. I mean, it's nice.
All right.
It's nice that they didn't damage the leaflet on the way out, that they actually made it
Isn't it nice?
Yeah.
I
I presume it was just a manual. Did they just do manual traction just to pull it out? No laser, right?
You're right. I don't think they did. I don't think they used the laser.
Yeah.
I can't know for sure, but I don't think so. It's pretty fresh. Next slide. And so it's all downhill from here in that you really see beautifully, and again, great imaging by Steve. We ended up putting in several clips. I believe there are 3 clips now. Oh, it's a long anteroseptal. So what looked like, central, even posterior, was really just that long septal leaflet. And so these are 3 XTWs, just zipping the anteroseptal coaptation plane. And he went home with trace tricuspid regurgitation.
Oh, great
And
demonstration.
I think that's the last slide.
Yeah. Great case, Matt. I felt, I thought the key learning points, the lead extraction consideration and the risk factors when considering for patient selection. Multimodality imaging besides TEE, like CT, which we do to evaluate these patients, especially, right, where you are considering lead cases where you're thinking of TTVR as well at the same time.
Right.
In your options. And then the target grasp, like you did after the lead extraction. And then, of course, discussion with your EP colleagues as well for these kind of cases. So anything else I'm missing, Matt and Steve, with regards to your case?
Yeah, it's just really difficult. I mean, these are really challenging cases, and at the moment when you're not sure is just acquiring a lot of different of clips, and not tri-clips, but shots of the valve, and really carefully moving that biplane cursor, and then with color, without, with color, and then like going back. It's really difficult, but the more information you can record and then review with your interventionalist, the better, and with the EP team as well, because it's really challenging imaging. And I would just say a lot of times, like, they put in the CS lead, and there's more draping over the tricuspid valve, so it can get it's hard.
Yeah.
Well, the last part I think is really where Hursh will let us know the data that he presented from TCT just 1 month ago from the pivotal trial on these patients who underwent TriClip and had CIED. So Hursh, take it away.
Sure, thank you. So thank you again, Nadira, for inviting me. This has been great. So just to remind everyone on the call, the Triluminate pivotal trial was a randomized controlled study of the TriClip device in symptomatic patients with severe tricuspid regurgitation with a concurrent single arm cohort, like we just talked about in one of the cases. The primary endpoint was met in full cohort, primarily driven by improvements in quality of life, and patients with the transvalvular CIED leads were eligible for enrollment and were screened by the eligibility committee. So there's actually a fair amount, 20% of subjects, and if you kind of drill down on it, there were about 30, maybe out of all the lead patient, out of all the rejections, there was only about 20% were due to the leads as well. So a fair amount of screened lead patients came into the trial. So approximately 20% of the subjects in the randomized arm and single arm, so the total trial had transvalvular CIED leads. So our aim was to assess one-year outcomes in subjects with the leads versus those without the leads in the whole trial, including the single cohort. And so this is what it looked like. So if you look at all the patients in the Triluminate pivotal trial, including the randomized and single arm, in the randomized, you'll notice that in the device, with the device, obviously we're only looking at device patients in this study. Most of them did not have the presence of a lead. So only 27 had a lead in the randomized arm. And I think that was, to your second case, Paul and Nadira, that we just, I think, assumed that a lead case was probably not going to get a big reduction in TR. And I think if we had, if we knew what we know now, I think we would have had a lot more in the randomized arm. Which would have been interesting, but only 27 were in the device arm, and in the single arm, 71, a higher percentage. So we compared that 71 plus 27 to the 254 plus 117 that didn't have leads. And so here are the characteristics. Basically, everything is similar, except for the lead patients were slightly older. You can see there on the top line, and they had a higher prevalence of renal disease, which you can see highlighted. The other main factors were very similar. So they were slightly sicker. Next. And if you look at the TR severity, numerically, there was more torrential TR, which kind of makes sense in the lead patients. Not surprisingly and understandably, the lead-induced CIED lead-induced patients were significantly higher because there were no leads in the other group. And so here's what's interesting. First, and there's probably a lot of reasons, and I'll state some reasons, we can talk about it, but there were less clips placed in the lead plus place. You can see 1.9 versus 2.2. That was significant. Also, the procedure time was less, and the device time was less. Now, if you look at it, that we used the G4, so the G4 came out, and I think a lot of patients were probably they probably waited until the G4 came in for independent grasping, and that might be one of the reasons. The other reason might be that I think we started including more lead patients later on the trial, so our experience got a little better. Or it could be that atrial TR versus lead-induced TR. Atrial TR tends to have more clips, maybe a lot more area of regurgitation, and maybe the lead is localized, but we could talk about all that. There could be reasons for that. But the main point being, it didn't make it harder in terms of time and number of clips. And if you look at it, there was low rates of major adverse events and major bleeding in the lead patients, as you can see on the bottom half of the slide, basically very similar with very low event rates, which all of us keep on talking about, that this is a very safe procedure, and the lead did not confer any added risk. And next, and there was a similar reduction to moderate or less tricuspid regurgitation in the lead patients. Again, that didn't affect the reduction in these carefully selected patients, despite having a numerically higher torrential TR at baseline. And if you look at New York Heart Association class through 1 year, there were significant and sustained improvements in heart failure symptoms, and that was observed regardless of the presence of a lead, as you can see there. And the KCCQ, which drove events, as you know, for the first year of the trial, there were significant and sustained improvements in quality of life, and that was observed regardless of presence of a lead. And again, there was no difference in all-cause mortality or heart failure hospitalization in at least at 1 year, and that didn't change despite having a lead. So here I kind of think is the main point. If you look at it, it is still a very safe overall. The Triluminate, the TriClip procedure is a very safe procedure, but it's also very safe in patients with leads. You can see if you look, there were 4 tricuspid valve interventions. I'll just kind of illustrate those. Those were actually all second clips, TriClips, and they all did very well with significant expected decrease in tricuspid regurgitation with no adverse clinical events. Two of them, one got delayed, was randomized, but there was thrombus on the lead, so they got their tricuspid clip later. So, but that counted as a tricuspid valve intervention. The other one, they tried, but they decided to wait for the G4 because that clip would have been better. That would have been easier, I think, for independent grasping to grab. And then the other 2 had residual TR after the TriClip, and they got another clip in each one of those cases, and they've done very well. So those are the individual 4. So even then, you call them adverse events, they all did very well in a safe procedure. And overall, the SLDA rate was less than the overall cohort. But again, that could be due to our experience, because I think we started allowing these patients in the trial later on. And so, key summary points: tricuspid TEER with the TriClip device was found to be safe and effective with subjects with transvalvular CIED leads. The presence of a lead did not increase procedure time. Significant TR reduction and improvements in quality of life were comparable. The tricuspid TEER with TriClip device did not impact the function of the lead. I didn't mention that in the last slide, but there were no events associated with what might be associated with a lead, as you might see in other trials where the lead was dislodged or the pericardial effusion or need for emergency pacemaker. There were no patients like that. Adverse events were infrequent. In tricuspid TEER with the TriClip device should be considered for the treatment of TR in patients with transvalvular CIED leads. But I would say even another statement that I said after this was that we shouldn't, the lead, this is what we were trying to understand, is the lead, and we didn't understand that when we were first enrolling patients, the lead does not confer for sure an added risk in selected patients. And you can safely treat these patients to more than 2 grade reduction and symptomatic improvement. But thanks.
Question for Hursh and Paul. How much do you think we evolved through the Triluminate trial? I'm guessing a lot, as far as skill and willingness to try more difficult things. Because I remember early on, the meetings, it was more, risk averse. Did we change a lot through the trial?
Yeah, in the beginning of the enrollment, when we were putting patients in single arm versus randomized, the single arm was basically where there's uncertainty. And we had a lot of uncertainty in the beginning. And so if you look at the differences, between the randomized arm and single arm, randomized arm had 16% rate of leads. Single arm was 35%. So it's like, it's not even close. So we shuttled a lot of lead patients there, but we learned a lot. And I to Hursh's point earlier, if we know now what we knew, if we knew then what we know now, it would have been a lot different. But we can't repeat the trial now. So
Plus the fact that imaging has improved so much.
Yes.
Resolution, and then now we have 3D
with
ice.
yeah.
And kudos to the vendors, really listening to us and knowing the difficulties, right, Steve, that we have, that we face in these cases. So, much more to come, I'm sure, from the imaging standpoint, with better imaging for sure, but certainly has improved so much.
Well, we're at the top of the hour, and I want to thank Nadira, Stephen, Hursh, Matthew. Wonderful cases. Just, it's amazing to Steve's point, what we do now and how we think about things differently. And I think tonight's cases and discussion was a great illustration of how we've all learned so much in the past several years. And we're still learning. And so it's just been fantastic. I want to thank Nadira for putting this together. Another fantastic of Nail It with Nadira webinar. And we look forward to seeing you at the next one. So thank you all and have a great evening.
Great. Thank you. Thank you,
everyone.
Nadira.
Thank
Good seeing
you.
you guys.
Thank you, everyone. Bye.
Bye.
Bye.